We will start in another 1 minute. Let's more people will join.
I think we have almost reached 50, sir. And maybe we can start. Dr. Neil, can we start now? Dr. Reena?
Yes, sure.
Okay.
Good evening, everyone. On behalf of Orphan India and Dr. Lal Path Labs, I would like to welcome all panelists and attendees in Second India Autoimmunity Seminar. This journey started on December 1st last year when we had organized First India Autoimmunity Seminar at New Delhi. As we all know, due to the COVID, we cannot organize regular seminar. Therefore, we all are here on virtual platform. So these are okay. So this was our first India Autoimmunity Seminar where we had all the faculty members like Dr. Anil, Dr. Malviya, and Professor Maroni from Milan, and all the dignitaries we have joined in the first India Autoimmunity Seminar. So scientific and agenda of these 2-day seminar is for day 1, 28 November today. We have topic on APS, looking beyond optic APS, which will be taken care by Dr. Vimlesh Pandey. Then Dr. Nenali will take second presentation today. Then tomorrow we have another two very interesting topics like specifics on ANA test, which Dr. Vijay Kumar Rao will take. And then Dr. Savino Sasha from Milan, he will take the second session in tomorrow session. I will just like to highlight that for both the days we have to register separately. And today's moderator of today's seminar is Dr. Anil Arora. Currently he is a HOD at Hematology and Immunology at National Referral Laboratory, Dr. Lal Path Labs, and his qualification is MD Pathology from D.Y. Patil Medical College, and he has key responsibility is national and international accreditation of all department launching new tests. So he is very experienced in the diagnostic, more than 10 years in Dr. Lal Path, and he is also trained in internal auditor as a ISO standard medical labs, and he has published various publications and poster in international and national conferences of, and also published in Journal of Reputes. So now Dr. Anil, you can take charge.
Good evening, everyone. As Dr. Vikas has told us, I welcome you all on behalf of Dr. Lal Path Labs and also Orphan Academy. So to this webinar, as already told by Dr. Vikas, we cannot have it on physically. We cannot be present due to the COVID timing, but okay, we didn't want it to let it go the opportunity of this having this autoimmunity seminar or symposium which we had last year also. So I welcome you all. Hope we will have a great time in listening to about APS and in the rheumatoid diseases, and especially today we have Daniele from Germany, who is from Welfare Academy, and Dr. Bimlesh also. So I hope you will have a good feast of the knowledge or a great lecture or a webinar from the two renowned speakers from India and also from abroad. So before we start that the knowledge feast and all, I'll like to invite Dr. Reena Nakra, who is also present in our panel. She is Director Lab Operations of Dr. Lal Path Lab. She'll be saying a few words about our vision, like how we see that autoimmunity testing at Dr. Lal Path Lab and how much importance we are giving it for this autoimmunity testing in Dr. Lal Path Lab. Now over to Dr. Reena Nakra.
Yeah, thank you, Dr. Anil. Good evening, everyone. It is my privilege to welcome you all to the second India Autoimmunity seminar. And We are embarking on this journey to establish the National Reference Lab as a center of excellence in autoimmunity. As you all know, are aware, Vikas, can you change the slide?
Yes.
The next slide.
Yes.
So, of course, the infrastructure that we have enables us to build the 3 pillars that are required for any center of excellence, which are, defined by the quality, the service offering, and of course, in the diagnostic space as well as in healthcare, we can never be far removed from academics and research, which is a core pillar for us. The next slide, please. So through our 200 labs and the 1,700 patient service centers, the pickup points close to 5,000, and our service offering of 4,500 tests, we promise an unmatched access to our patients. So wherever they are in their geographic location, we can help them reach the vast test menu that we have in our offering. The fully automated platforms, which work on international protocols, are manned by skilled expertise, strengthened by the quality we have, the logistics that we maintain, and also the information through LIMS and a centralized, very standardized, scalable LIMS that we have. We are able to build this infrastructure on which we can give this offering. Next slide, please. Quality for us is one of our core value, and we look at continuous improvement in our report formats, looking at how we can increase the test menu offering to our patients and the clinicians, pay continuous focus on to the pre-analytic, analytic, and the post-analytic workflows, so conforming to the highest accreditation guidelines. For us, each report is like, we would like to personalize each report. And to achieve that end, it is in our endeavor to be able to build this journey along with the clinicians as to what can, and keep the patients as the center as to what can we give in each report that matters the most. Next slide. As a service offering, we have in our autoimmunity segment more than 100 plus tests. We are expanding the menu to even have more esoteric testing, to have testing for rare diseases like paraneoplastic syndromes, autoimmune encephalitis. There are research projects which are on. Next slide, please. And we are doing some research work with the help of Dr. Malvia, and there is an academic program that we run in our National Reference Lab. We are accredited by the National Board for the D&D in pathology, and we have students with us. We would like to, now start some fellowship programs and continue the ethos of education and research, which would be the pillar for our Center of Excellence. I am really privileged to be, sharing this platform with the esteemed panelists, and I welcome you all once again. And I would request Dr. Anil to take forward the program. Thank you so much.
Thanks, Dr. Reena. Thanks for giving us insight about Dr. Lal Path Labs, things about autoimmunity testing. Now we'll like to move towards the real feast of knowledge. So we'll be starting our today's webinar with the first presentation, that is by Dr. Bimlesh Dharpande. I think most of people, we all know about Dr. Bimlesh, like we have heard about him everywhere. Like right now he's working as a senior consultant in rheumatology at Fortis Hospital, Noida. He has done his MBBS from Calicut University and MD in internal medicine from Vim's Ranchi. He's done his senior residency in AIMS in rheumatology, and he has got various trainings and all in all foreign countries and all. We all know Dr. Bimlesh, and he'll be talking to us about like will be taking us on a ride about the antiphospholipid antibody syndromes. Like there, we have got a lot more in that APS category than usually we think. So I think Dr. Bimlesh, he will share his screen right now, and will take us through about the journey of the APS. To you, sir.
Thank you, Dr. Anil. Thanks for your kind words. Thanks to Dr. Lal Path Labs and Burfen India. They've asked me to speak on this topic. Very interesting to me because I love this topic as much anyone. It's quite intrigue, and it's a journey that I will try to understand throughout my life. That is how I describe antiphospholipid syndrome. I think my voice is audible to everyone. If there are, please do let me know through the chat or communication. So the first slide is what I remember, Graham Hughes. And during COVID time, since we can't uh, be physically present and share our views, webinars uh, is the way out, and it's quite a, it has had a profound effect on of how we change or exchange ideas. The science has moved on during pandemic. So this mask from the Graham Hughes charity is just symbolization of how uh, things have changed, and what started in 1983 as Hughes syndrome, now we call as antiphospholipid syndrome. So this is a journey I'll just go through. And this one word, exploring the stickiness, is again Professor Hughes' word. He uses the word sticky blood. So I've used this typical word where it's almost a way of speaking thanks to Professor Hughes of how he used to describe this terminology. So we all know about this condition, antiphospholipid syndrome, and we know that it is basically two, and we can also say the third. One is a thrombotic uh, variety, and one is associated with pregnancy, obstetric, and the last but not least is the catastrophic APS. And we all know that there's such a classically defined thrombosis which can happen both in arteries and vein. And the nightmare of catastrophic APS, either it's the patient or the clinician. One can go on discussing uh, at great length to achieve, that we could not do something we thought of doing for the patients. And what we know that this is a disease which involves the arteries, the vein, and microvasculature. So that's very important to understand, just not an artery or vein, but also microvasculature. And it's an autoimmune condition because we know that it is associated with uh, autoantibodies. So this is how the revised classification criteria of antiphospholipid syndrome is basically into two compartments, the clinical arm and the lab arm. The clinical arm has vascular complication or pregnancy complication, and we need to fulfill those to be in the clinical arm in the classification criteria. And then you have a lab criteria where you have got three classically described uh, autoantibodies, which are lupus anticoagulant and autoantibodies to of IgG, IgM to anticardiolipin, and autoantibodies to beta 2 glycoprotein. So this is how you have it has been described. And this lupus anticoagulant, where you have the word lupus attached to it, which is basically a misnomer, and it is not anticoagulant, it is a coagulant, but then this misnomer goes on and goes on. So what we know in the pathogenesis of this disease, that in majority of the thrombotic diseases, you have a second hit phenomena where there's an inflammatory stimulus in a predisposed individual, say beta 2 glycoprotein dependent antiphospholipid, which has undergone certain post-transcriptional modification, and intracellular signaling pathways are there with specific epitope specificity. This is a milieu in which you have combination of antibody and a stimulus leading to an outcome, and the outcome can be on the targets like endothelium of the blood vessels, the monocytes, the platelets, and the coagulation factors. They all become part and parcel of this whole orchestra, and then you have add-on complement activation and you get a clotting. Very well described way back into 2014 by Professor Meroni, and we miss him today because last year we shared an excellent meeting where he shared his thought process. So moving beyond the thrombotic, we can also have a view of how it is different in obstetric. In obstetric, it is not the second hit, it is the pregnancy hormone. And similarly, you have the, beta 2 glycoprotein dependent antiphospholipids, which again has undergone some amount of transcriptional modification, intracellular cellular signaling pathways has been activated, and there's a very specific epitope specificity in which there is a binding, and this all leads to a cascade of event where the target is decidual cells and trophoblast, and then you have again a complement activation, complication in the pregnancy. So basically, this is how the pathogenesis. And what we know that beta 2 glycoprotein is just a protein which is folded, but when it is exposed, it looks like a J, or you can even call it L, and then you have antibodies against this beta 2 glycoprotein where it is attached by the domain 5 onto the phospholipid, and the domain 1 is exposed, and the beta 2 glycoprotein sits onto the domain 1, and in an oxidative states you have two dimerization and of this phenomenon. So how does antiphospholipid causes APS is a question that one needs to understand, that a single antiphospholipid will cross-link with two beta 2 glycoprotein by binding at the D1 site. This is what I was trying to give, and this complex of trimolecular complex where the domain 5 is sitting onto the phospholipid, making a trimolecular complex binding, leads to the recruitment of certain recruitment of receptors on the toll-like receptor pathway, especially the 4, which triggers intracellular signaling, causing NF-kappa B expression and MAP kinase pathway. Work again very well taken from Anisur Rahman's description, again a legend in antiphospholipid syndrome. So when I speak on this, I also mean to say that this pathway can also have certain potentialities that we can hit or target this or target this or target this in future treatment protocols. So this is why it's so fascinating that there are a lot of challenges in this disease. At one point of time, you can be proactive, and the other time you can have a caution where you are too cautious. And the caution and the proactiveness is what is so interesting. So let me give you an idea. This disease is very simple. If you have a person who comes with certain symptoms, who has been evaluated, and his evaluation has no symptoms and he has a negative serology, you are happy, the patient is happy, there's no complication, you don't want to intervene further. There are certain times where patient comes with serology which is positive, and there's a positive symptom. You try to value those positive symptoms and serology and allocate a treatment protocol. So you try to understand the disease and its complication and take a treatment option. Then you have a person who is having a positive serology and no symptoms. What do you do then? Do you want to treat them because you know that this can potentially lead to a problem? So are you happy, or are you willing to take that effort to treat a person who has no symptoms? Probably in medical science we do not treat serologies, but we'd like to treat symptoms. But there would be odd patient who would be not of major symptoms but has a positive serology. What do you do then? And those are the certain questions I will be hitting and I will be discussing. Then you have another set of questions where you have negative serology and your classical serological test has not helped you, but the patient has positive symptoms, and then you can't help. You know that it is an antiphospholipid syndrome, but it is behaving like a seronegative, and then this is the deficiency of understanding this disease, that we have been describing this disease with only 3 lab arms, and you can have multiple lab values or lab tests which can actually help you. But are you willing to do all sets of investigation to identify or rectify negative serology? So there's again a question. So to make things even simple, 5% of the population may have positive serology. So what do? Do you want to treat them? No. Is that exactly like HLA-B27? If you have HLA-B27 and if you do not have symptoms, you don't treat HLA-B27. You try to treat symptoms. But if you don't have symptoms, but then you have certain complications, what do? Whether it's a thrombotic or obstetric or CAPS or combination of thrombotic and catastrophic, if you have those complications in future, the question is, do we have a predictive algorithm as on today? We do not have, but are people looking into this predictive algorithm? Yes, that's the most important. And are we following them? This answer is we need to follow them, because there are certain signals which are strong enough, which gives us a clue that how we need to move forward in understanding, predicting. So there should be a good predictive model in a disease which is so rare. So it is again a time-taking effort. So that's why there are difficult questions that we need to wait for an event to happen. You can't have all your answers, all your questions answered. It's very difficult. So we don't treat positive patients, and we do not treat patients for anything else but to prevent further happening, because we are not doing a preventive treatment protocol. We are doing secondary treatment. So we don't want a person to suffer, whether it's a thrombotic or obstetric complication. So primary prevention is probably not possible. This is something which I understand and I would like to always speak, but there will be certain points that will digress from this understanding that we hold today. And there's another question that always ponders my mind: pregnancy losses. How many pregnancy losses would you need to accept it that it can be a complication of APS in a reproductive age group? So do you want 3 pregnancy loss, which I don't understand or which I don't agree, because majority of people are marrying late and they are not, and they're conceiving late. So even a single pregnancy loss is a big loss. So we need to understand this point and we need to be proactive. So those classification criteria require certain tweaking in future. Now, if we have treatment, why are we so unhappy with the treatment? We are all unhappy while we are happy that we are able to save certain lives, have a better quality of life. But then we know that drugs are associated with more bleeding. It can be life-threatening bleeding too. We do require a lot of monitoring these patients, so they cannot be on a telemetry approach. The way we can share our thought process, they require monitoring. They need to visit a lab. They need to get their INR done if they are on warfarin. And there are a lot of interaction of this drug, and that we need to take in care. It's so difficult. There are certain times we require injections, and some of our drugs are injectable in our treatment protocol, which is again a problem. And we know that certain drugs, especially heparin, can cause long-term use, can cause osteoporosis. And there are certain issues like safety during pregnancy for a patient who has had obstetric complications. So we can't give them warfarin or vitamin K antagonist because they affect adversely. And there are a lot of dietary issues. So as a human being, I would like to eat what I'm used to take on a day-to-day basis. But when I'm told about the list of drugs which I can take and not take, it makes me even feel more as a patient while we are suffering this disease. Then there are certain questions that we need to understand, and we should be very cautious. So when there are certain topics in this disease, so we have a laid down thrombotic disease, we have laid down obstetric disease, we have laid down catastrophic antiphospholipid disease, but then there is a gray area in APS, which is called as non-criteria disease. So will you try to give a warfarin to any patient who comes with migraine? No, you can't. So you need to evaluate, you need to work up, you need to prove that it is a part of non-criteria APS. So that is how you have to be quite cautious, and a lot of effort is required. You can have musculoskeletal issues with the disease. I will be again going forward to in the next slide. So this mild joint pain and the fatigue is just not antiphospholipid. There are another hundreds of causes which can cause this. Let us say vitamin D is the commonest cause for a joint pain in India. Then you have autoimmune disease, which you can have lupus, you can have fibromyalgia, which may be there in an individual with joint pain, and they may be labeled APS because they have one test which is positive in their serology, a mild positive, beta 2 glycoprotein levels. So what do you do then? So it's again a problem. So we need to take in account the clinical context before we jump. So it's not the lab test which is going to help you all the time. Your clinical condition needs to be evaluated for all the clinical subsets before we label a patient with antiphospholipid. So then you have diseases with skin involvement like livedo reticularis or racemosal pattern. What do? Do you have a great drug? Or do you want to give a drug like warfarin for livedo reticularis? I am not happy to say that we do not have an excellent drug for this condition. And what do you do with thrombocytopenia, which is not life-threatening, but is associated with an antibody? So it may be an APS, which is not causing any problem other than just isolated thrombocytopenia. And that needs to be looked into, that whether there's a gravity which needs to be taken, that the situation is so grave that you need to give a treatment for a prolonged period of time. And there is an issue that if you have an APS which is a mild, can we just use hydroxychloroquine? And that is where Munthar Kamasta is so vociferous and says, not vociferous, is so passionate to say hydroxychloroquine may be the easiest way out for some of your pains, and you don't require steroids. And we actually require a lot of better drugs for our treatment in APS. So that's another question. And the thing is, in APS, it's very slow. So you have a disease which is so rare, and then you want a randomized controlled trial, then you have a newer agents based on the hypothesis. It takes a hell of a time to achieve that conclusion whether the newer drug is going to be beneficial. And I will be talking on this point maybe almost at the end of my discussion. So it's very important to risk profile a clinical context and put in whether you have an anticipation that the condition may worse, or do you have a condition which is already worse and you want to treat. So this is something very important to look. You have a context where you have a carrier who's not having any disease but has triple positive lab report. So he has a higher risk of having events per 100 patient years compared to a single positive and compared to a normal. So this is where you need to understand the whole context. So even if you are asymptomatic, you don't have a clinical disease, but if you are just positive, this is what you need to know. So and this is the answer which I would like to share with my patient. That's why I won't treat these patients unless they have that event. And then when you follow up over a period of time, you will come across things happening. Exactly like what is seen in anti-CCP positive individuals. They develop RA after certain years. You don't treat a patient of RA, of a patient who has anti-CCP but no symptoms. So that's exactly the same situation here. And that is exactly what I would like to speak, that if you have anti-CCP in a strong high titers, rheumatoid factor in a very high titers, but no clinical context, you don't treat unless they either have a clinically significant arthralgias or undifferentiated arthritis or a full-blown arthritis. So similar is here. And then we need to understand the concept of low-risk APL profile, the high-risk APL profile, and the medium-high APL titers. So that is very, very important, that you need to define the cutoffs. If you do not have cutoffs, everyone will have their own version of what they understand high, low, and medium. So medium and high risk APL titers have been described, and a high risk APL profile has been also described very well. So you need to have a test which is significantly high on 2 occasions which are 12 weeks apart, and the methods as described by the International Society of the Hematologist. So that needs to be there, and presence in a high titers is a high risk APL profile. And then you also have a low risk APL profile. Among all the risk profile, one needs to understand lupus anticoagulant has the highest, and anticardiolipin would be the lowest. So EULA recommends prevention and management So there is a recommendation while we are speaking that there isn't any prevention strategy, but there are certain prevention strategies which can be as simple as a low dose aspirin or hydroxychloroquine. So we need to stratify antiphospholipid positive individuals and determine whether they are of a high risk profile or not, as per the definition. And there is a history of thrombosis or obstetric APS and other systemic autoimmune disease like lupus, or there are cardiovascular risk factors, then you can give a preventive. So that's very important, when you cannot give and when you should give. And the risk measures for APL positive individuals should include the screening for strict control of cardiovascular risk factors. So it's very important that we just do not want the thrombosis to be prevented. You require a smoking cessation, management of hypertension, dyslipidemia, diabetes, and physical activity while you want to prevent an APS episode, a TAPS, a thrombotic APS. So very, very important. Just not the lab is very important. You require other things also. And the last but not least would be the patient education. So you may give them the option of taking vitamin K antagonist, and you are using a low molecular weight heparin. You need to tell them when to take, how to take, what are the interaction, when you should not use, when you should use. So those lifestyle recommendations, diet, exercise, they are all part of your APS. So when you would like a primary thrombosis prevention, the first thing is the traditional risk factors that needs to be tackled, which are smoking cessation, control of hypertension, sedentary behavior needs to be changed, dyslipidemia needs to be treated, and then you can use hydroxychloroquine for primary thrombosis prevention, in which high risk APL profile, they never had a thrombosis, they never had an obstetric complication, they never had CAPS, asymptomatic APL carriers. Patient with history of obstetric APS without SLE, they can just take hydroxychloroquine. And you can also give hydroxychloroquine for non-criteria APS manifestations, say thrombocytopenia, a heart valve disease associated with APL, and say nephropathy. And there are certain good work which also say that statins and coenzyme Q10 can be a good agent for primary thrombosis prevention. There are recommendations again from the EULAR with agreement levels achieved, and you can see that primary thromboprophylaxis for APL positive subjects is there, and they go on to say, as per the EULAR, a low dose aspirin, anything between 75 to 100 milligrams is called as low dose aspirin. That's very important, because some people from America may come and say, my low dose aspirin is 81 milligram. What do you have in India? We say we commonly use 75. So these are certain things that we need to do, and this is a very important concept that came from EULAR, which is hotly debated at multiple different platforms. The hematologists may not agree to this point, but the rheumatologists feel that this is a something which helps our patient. In a patient with SLE and no history of thrombosis or pregnancy complication, but they have a high risk APL profile, again you can give low dose aspirin. With a low risk APL profile, you may use may use low dose aspirin. So it's very important that you need to identify this risk, and that's what I spoke about some time back. The non-pregnant woman with a history of obstetric APS only, with or without SLE, prophylactic treatment with low dose aspirin after adequate risk benefit evaluation is recommended. So it's again very important. So then you have a secondary thromboprophylaxis for APS, and we do not have a doubt on this, that what you need to do, whether it's an arterial or venous, and what is your INR that you should achieve for treatment for the venous thrombosis, what you need to do for the arterial thrombosis. One thing is very clear, that the DOACs, the rivaroxaban, and the other agents, the newer age oral anticoagulants, which are quite specific on the site where they act, should, whether they are anti-thrombin inhibitors or whether they are factor 10 inhibitors. Rivaroxaban should not be used in patients with triple APL. That's very, very important. And DOAC should be considered in patients not able to achieve target INR despite good adherence to VK, that is vitamin K antagonist, and those with contraindication to VK. There's only one indication where you can use it. And in a patient with unprovoked first venous thrombosis, anticoagulation should be continued long term. That's very, very important. So needs to understand that if we start treatment, they should be convinced enough to treat, and we need to treat them for long. Then in patient with definite APS, recurrent venous thrombosis, despite treatment with vitamin K antagonist, with the target 2 to 3, investigation and education on adherence to this agent, along with frequent INR testing should be considered. So a very, very important message. And if the treatment target INR has been achieved, addition of low dose aspirin, because you are getting more thrombosis in between, increase INR to 3 or 4, or change the low to low molecular weight heparin can be also considered. In a patient with definite APS and first arterial thrombosis, this context, the treatment of VK, that is vitamin K antagonist, is recommended over treatment of low dose aspirin only. So treatment with vitamin K antagonist, target of 2 to 3 or 3 to 4 is recommended depending upon the site. Considering the individual's risk of bleeding and recurrent thrombosis, this is how you need to take in consideration. Rivaroxaban should not be used in patient with triple APL positive. So in recurrent arterial thrombosis, what do you do if you get a patient who gets more again and again every second year gets a thrombosis in some of their arteries? Treatment with vitamin K antagonist after evaluating for other potential causes and increase the INR target to 3 to 4. Addition of low dose aspirin, switching to low molecular weight heparin is again important. Since I'm not touching obstetric APS, that's why I'm going to skip it. But something very interesting is catastrophic APS. And if you see the catastrophic APS, the first line treatment of patient of CAPS is combination of steroids, heparin and plasma exchange. And it says that this spectrum disease has different players in the orchestra contributing to disease form. So APS usual does not require any steroid, but here you would require a steroid. Heparin, plasma exchange, and intravenous immunoglobulins are all standard treatment, and you may require a B cell depletion or a complement inhibitors also many times. So secondary thrombosis prevention is a very different ball game, and there are a lot of study literature available to speak on this point. So controlled studies on the efficacy and safety of different with the agents is well described. We also know the duration of vitamin K antagonist in provoked first venous thrombosis. The controlled studies on the efficacy of vitamin K antagonist alone versus vitamin K antagonist with hydroxychloroquine in the very first arterial thrombosis is something that is being debated and being aggressively looked into. The targeted therapies like B cell depletion, complement inhibitors, and mammalian target of rapamycin, mTOR, for recurrent arterial thrombosis events, despite treatment with an adequate INR goal, is again hotly debated and looked upon. The adjunctive treatment of recurrent arterial thrombosis would be hydroxychloroquine, vitamin D, statin, platelet inhibitors other than low-dose aspirin can be also thought into, like clopidogrel or ADP receptor inhibitors or adenosine reuptake inhibitors, etc. And discontinuation of vitamin K antagonist when a patient becomes persistently negative for APL in repeated measurements is again a very important concept. So this is how, again, the disease pathogenesis has to be looked, because the treatment targets can be anything, because if you have a thrombosis, you look aspirin, anticoagulants, or both, then you can have different agents which can work on the complement activation, antiplatelets, and drugs which work on monocytes and endothelial cells, because these are very important, because if you would like to hit, you can use sirolimus, the mTOR inhibitors, which prevents the cell growth or cell proliferation or cell survival. And so this is a spectrum disease, and you will have a lot of views, just like your moon during the 15 days of its journey or 14 days of its journey, you will see various shapes of moon. So non-criteria manifestations are usually refractory to standard APS treatment, that we need to understand. And CAPS, the catastrophic APS, is very severe with a very high mortality, around 40%. And they are treated actually in a very different model. And we need to understand in APS, prothrombotic, pro-inflammatory, and angiogenic pathways, they all lead to pathogenesis of thrombosis. Now, these are the conditions which are not the classical manifestations, but these are what you see in antiphospholipid syndrome, like thrombocytopenia, the heart valve disease, the skin, and the kidney involvement, especially thrombotic microangiopathy, is very, very important and very dangerous condition. And then you have a various CNS manifestations, which includes usual, the basic headaches, the migraine, the epilepsies, and multiple sclerosis-like disease. You can get dementias, the ocular manifestations, the transverse myelitis, pulmonary hemorrhage is very, very rare with very poor outcome. So if you go on, you can see the association in the primary APS, how many patients will have thrombocytopenia, around 25. Heart valve disease in primary APS, if you look into the cohort, you will see around 33%. One third, they have heart valve disease. And again, in a primary antiphospholipid, around 1/4 will have livedo reticularis, 1/3 may have ulcers on the skin. So this is very, very intriguing that you may be treating the other components because they are the major components. So there are criteria for identifying the clinical context, and there are non-criteria context, which I was briefly mentioning, but there are also non-criteria antiphospholipid antibodies, which are associated with clinical phenotypes. And in another 5 minutes, I will try to highlight that they are so complex. So there are a huge number of non-criteria antiphospholipid antibodies. They're not one, you have around 20, and this is the list. And you can see the the sensitivity, specificity on various scales, and you can calculate what is more important. So if you do the spectrum analysis of all the autoantibodies, this is the number of autoantibodies, and various studies have actually looked into it. This, especially the anti-prothrombin antibodies, what is its association with the clinical manifestations? And some studies are they are in positive correlation, and some are in negative correlations. What we know as on today, if you have multiple antiphospholipids, say more than 7, arterial thrombosis is the commonest APS phenotype. And in the CNS manifestation, you have got this as a typical presentation. The venous thrombosis would be associated antiphospholipid is this, and there are odds ratio, which is well described, and the pregnancy morbidity. So there are different autoantibodies, and this autoantibodies may lead to a different clinical spectrum. This is important. So non-criteria APL, antiphospholipid antibodies, you have anti-beta 2 glycoprotein 1, domain 1 antibody is associated with thrombosis and pregnancy complication, while IgA, anti-beta 2 glycoprotein, is associated with hypertension and seizures. So this is a difference. So they both are anti-beta 2 glycoprotein, but there is a difference. And anti-PS and PT and PS is manifestation with a different profile. So if you have an anti-vimentin, correlation is with thrombotic events and pregnancy morbidity. So it's very, very complex, but still people are coming to a reasonable conclusion after collecting various registries and filling up the dots. What is there which we need to understand while we try to treat? So if I say it, just to suffice that incidence of thromboembolic episodes in asymptomatic carriers of IgA type of anti-beta 2 glycoprotein antibodies is very different. They are antibodies against domain 3, 4, or 5 IgA types. It leads to a different complication, and one which is associated with domain 1 leads to a different complication. This is where I was trying to head on. The presence of immune complexes, again, which are bound to IgG and IgM beta 2 glycoprotein in a non-criteria clinical manifestation has a very, very different outcome. So the presence of beta 2 glycoprotein antibodies against this with complexes, immune complexes, is strongly associated with several non-criteria clinical manifestation of APS and a higher complement consumption. So this is where you get a difference. So non-criteria antiphospholipid antibodies will help to identify not less than 60% of those patients who were not being treated because they may fulfill one of the arm and they may be labeled as seronegative, and you're not very sure whether they require a treatment or not, and you're looking into different diseases altogether, whether they have some other disease. And it's very important to understand this part. So when you do not have an answer, so you may actually require all sets of investigation. But if you have an answer, the first 3 investigations that is known is very important. What happens if you're treating a patient? Don't be very happy with the treatment that you are giving. because 20% of patients will experience recurrences of around by 3.5 years, and around 7.3 and 16.3 years, depending upon type of the prophylaxis you are giving. So if you are giving a combination prophylaxis, say low dose aspirin, and you are giving, if you're just giving anticoagulant and antiplatelet and combined therapy. So if you give a combination of antiplatelet and anticoagulant, it is 16.3 years it may take for you to get the second episode. While if you're giving any drug like say anticoagulant, you will get 7.3, and it's only 3.4 years for antiplatelets. So different agents, you get a different outcome. So, but still there are no consensus, which is the best approach to management of APS. And combination of antiplatelet and anticoagulant may decrease the risk of thrombosis, but a very high risk of bleeding. So this is very important. So there are a lot of other different key members in this orchestra, and we need to just remember toll-like receptors and annexin-2 low-density lipoprotein receptor-related protein called LRP8, MAP kinase pathway, NF-kappa B pathway. The prothrombotic and the pro-inflammatory phenotypes are different. What is the role of each players in their contribution? We are still not there, and how to control this. There was beautiful studies on RCTs on the newer oral anticoagulant, which has give us a mixed feeling. It must be avoided in patients with arterial thrombosis and triple positive. These are basic. So moving forward, low dose aspirin for primary prevention of thrombosis in patients with persistent antiphospholipid antibodies is something that we look forward. There are a lot of articles which speak about low dose aspirin as a strategy, and there are certain other theories which says that if we decrease the type 1 interferon signature, we can decrease primary antiphospholipid manifestations, and hydroxychloroquine does the same. But if you see that you need to actually identify who's the individual who has a high interferon signature in a patient who has SLE. So in SLE, you have around 52% of the patient population which may have a high type 1 interferon signature, while 47 has a low interferon. So here hydroxychloroquine is much more effective than in this signature. So this is very, very, very important. So again, going back where these are our sites which we can use, and there are probably new agents. We have adopted certain agents like rituximab, eculizumab, which are B cell and complement receptor in pathway blocking agents. Then you have anti-neutrophil and anti-TNF, especially with certolizumab, good number of articles. But we need to get a D1 blocker, domain 1 blockers and domain 5 blockers in near future to have a better control. And at this point, I would thank you for your patience.
Yeah, I hope I'm audible now. Like I got messages in the chat that I'm not audible. So, I'd like to thank Dr. Bimlesh for such a great journey. He started it from the ISTH guidelines to ULR guidelines, recommendations in the treatment from a low dose aspirin to vitamin K antagonist to rituximab to low molecular weight heparin, whatnot, including each and everything in this presentation, and even the role of PSPT or domain 1, everything was included. Thanks a lot, Dr. Bimlesh, for such a nice presentation. So now we know we are already short on the time. So without wasting the time, I would like to move it to the next presentation, and I'll request Dr. Daniele from Welfare Academy to please.
I cannot share actually my screen as if I'm disabled, so I don't know how if I can get the habilitation to share my presentation because I cannot do anymore at the moment.
I think
now yes.
Yes. So now, yeah, I'll hand over the stage or the arena to the Dr. Daniele from Welfare. He's
yeah. Can you see the screen?
Yeah, we can see the screen. Yeah. So he's quite a renowned speaker on autoimmunity. Like he's always there whenever we go to any seminars or any symposiums in international conference everywhere. He's a PhD in clinical immunology and from the Department of Molecular Medicine, University of Germany. He's involved in n number of researches and taking place in especially in CTDs and all those things. So, without wasting much of time, I'll hand over the mic to Nele to take us to a journey of rheumatoid arthritis. Like now, will let us know about the autoantibodies profile approach in the management of rheumatoid arthritis. Over to you, Daniele.
Thank you very much, Dr. Aurora. I would like also to thank Dr. Path Labs and my colleagues from Werfen, India, to organize this event. It's a pity not being there for a live event. However, I think those virtual events are very powerful because I can see over 100 participants. So I think it can be very helpful. And so what I will try to do today, talking about rheumatoid arthritis, as you can see from the title, our intention as Innova Diagnostics, as a company specialized in diagnostic, is to change the current paradigm that we have in rheumatoid arthritis. And we would like to do so using and implementing autoantibodies profile approach to manage patients with rheumatoid arthritis. We know very well that rheumatoid arthritis, but in general autoimmune disorders, early diagnosis is very important because it gives us a windows of opportunity in which we can really prevent the destruction of the joints, for example, in the case of rheumatoid arthritis, and more importantly, we can block the progression of the disease. However, we know very well that it still takes some time to get diagnosed. So on average, a patient with autoimmune disorders gets more than around 4.5 years to be diagnosed with the right disorder, and almost 5 clinicians visits, which is a lot. So one of our intention is to reduce this timing in order to identify patients at an early stage, also considering the fact that mortality is very significant in some disorders. Also, rheumatoid arthritis, we know that some patients can develop, for example, interstitial lung disease, so lung fibrosis, and this can be one of the causes of death on these patients. And so if we can identify the patients as early as possible, we can avoid and reduce dramatically also the mortality. So let's talk about a bit of background of rheumatoid arthritis, so in general inflammatory arthritis clinics. We know that, for example, compared to APS, rheumatoid arthritis has a prevalence of up to 1% of the population. So we cannot really talk in this case of a rare disorder, but it's a disease that 1% represent a big portion, a big number of patients. How do we classify, how do we identify patients with rheumatoid arthritis? Here you can see the 2 published classification criteria. The first one was in 1987 by the ACR Euler, and back in that time, 23 years ago, there was basically only one serological biomarker that was included, which was rheumatoid factor that has been there since over 60 years. But as I will show you, there are some limitations related to this biomarker. Around 10 years later, situation slightly improved in terms of serology because another biomarker was included in the criteria, which is the widely used anti-citrullinated peptide antibody. And so you can see that the combination of serology can give up to 3 points in terms of scoring to determine positivity and so to assess the presence of rheumatoid arthritis in a specific patient. What I would like to underline about the latest and a bit outdated now, because we are talking about 10 years ago, classification criteria, is that the biggest portion of the scoring system is still related to the clinical observation, so to the clinical manifestation, because depending on the number of joints, we can have up to 5 points, so more than the serology itself, plus also duration of symptoms and some general inflammatory biomarkers. So you can see from this graph, from this table, that the serological impact is not so prominent yet in the definition of patients with rheumatoid arthritis. So there is a clear need to have new biomarkers also because, as I will show you during the presentation, there are still a significant number of patients which will be negative for both rheumatoid factor and ACPA antibodies. Another important aspect which I think needs to be underlined related to rheumatoid arthritis is that from an health economics perspective, we see that a specific cluster of drugs such as Humira, etanercept, or rituximab, infliximab, those are all biologics drugs which are inhibiting specifically, for example, TNF-alpha, or we are inhibiting other important molecule in the immune system. And the expenses are extremely high. So we see that from health economic side, the Humira alone, it accounts for almost $19 billion US dollars expensive. So to manage those patients is a very, very expensive thing. And the problem, because it's very expensive, but if we analyze how effective are those drugs used for rheumatoid arthritis, there was a nice review on Nature 5 years ago talking about imprecision medicine. So we keep talking about precision medicine. We would like to have in the near future specific drugs that can treat patients based on different profiles. However, if we see the Humira, the adalimumab, which is, as I said, the top pharma drug, we see that the majority are non-responders. So only a small portion of patients will be responding to the treatment. So they are very expensive drugs and they do not work on all the patients. So you can see there are several challenges also from a therapeutical point of view. So our idea and how we are addressing our research is to develop a treat-to-target therapy. So to be able to stratify patients based on different biomarkers tools, and by stratifying those patients, to be able to characterize clusters of patients in which a specific drug can be given to treat in a proper way those clusters of patients. In principle, if I have a specific serotype, so using also some stratification tools, I can assign the right drug to the right patients. So this is our endpoint where we would like to go in some years. Those are the pillars which are, I think, important in RA, but not only. So from one side, we talk about prediction and prevention, and we are also doing some trials to see if we can stop the development of rheumatoid arthritis at a very early stage. Then, of course, to diagnose, because as I said, there are still several patients which are seronegative to the two recommended biomarkers. We need also some tools to stratify the risk of patients, understanding if the disease will be aggressive, which organs will be involved, for example. We also need to know, as I said, which drug will be giving a positive response, so which therapy will be optimal for the patients. And of course, also we need some tools to monitor the patients, so the activity of the disease, and to tell us in advance how the situation will evolve in that specific patient. I think this graph is very indicative because it shows very simply how we can change the course of rheumatoid arthritis in different patients. In fact, if you see in a yellow line, if we do not intervene at all and the disease does its natural course, the progression is exponential. So you can see that the progression will go very, very fast and aggressive. However, already if we intervene at a late stage, so we identify the patients when the damage is there, but we still provide a treatment, we can already deflect the curve, so have improved evolution. But of course, the situation would be totally different if we are able to identify those patients at a very early stage. And you can see that the evolution of the disease will be not very aggressive. So the earlier we intervene, the better is the progression of the disease. And this is a very important aspect that I would like also here again to underline. When we talk about serology, so we said that there are two biomarkers which are today, two classes of biomarkers which are today recommended by the criteria. We talked about the citrullinated peptide, which is now widely used everywhere in the world. There are also some other isotypes, which, for example, we have developed as Innova, which include the IgA and can show some advantage over the CCP3 IgG only. And then we have the rheumatoid factor, which is widely used, mostly in the IgM. But as you can see in red here, in bold red, there are some emerging biomarkers, such as the anti-PAD family antibodies, the anti-CARP, or the circulating calprotectin, which they are, in the case of the first two, they are not yet launched. So we are working on these two family, and I will discuss more in details. And also the circulating calprotectin, which is now becoming more and more adopted in the US and in Europe, which is a very important marker for autoinflammation. And I will try to go more in details into those biomarkers to show you the benefit of implementing new autoantibody search to better characterize patients with rheumatoid arthritis. So we said rheumatoid factor has been the first biomarker that was already, I mean, is used by almost over 60 years of time. It was there already in the criteria over 30 years ago. We know that the prevalence it's quite good because depending on the cohort, we can detect up to 80% of patients. However, we know also very well that the negative predictive value and positive predictive value are not really optimal. In fact, we know that individuals can have a normal level of RF, but we can have up to 5% of healthy individuals that will display positivity, so giving a false positive result, and other comorbidities, such as other connective tissue disorders or also viral infection or bacterial infection can also influence the level of rheumatoid factor. So it is a great, it is a good biomarker, but it's not really specific and not very sensitive. As I said, there are three major isotypes. The one that is normally used in the laboratory is the IgM immunoglobulin type, which is found in 60 to 70%. The IgG is nowadays not very used because it's very specific, but there is a very low prevalence. And the IgA itself gives, in some papers, are showing association with a more severe erosive disease. So this was the RF, and I think today in India also is widely used. But the situation changed when the citrulinated peptide was introduced in the guideline, because we know very well that some proteins, some peptides can be citrulinated, and usually this citrullination is not observed and in a steady state condition when the joints are fine. And this is way more specific than rheumatoid factor because we can find over 80% of positive patients with RA, and 50% of them will already have reactivity to this citrulinated peptide in an early phase. So it can be very powerful because it can precede in certain patients the clinical manifestation by many years. And so the CCP is now widely used in the laboratory and has been a big addition to detect and to characterize patients with rheumatoid arthritis. But as we said at the beginning, our idea is to identify those patients at an early stage. So when the disease is not fully spread, when the joints inflammation is not so systemic. But the problem is here, as you can see, that if we combine together the rheumatoid factor and the citrulinated peptide, only 50% of patients will display positivity. So we will find autoantibody in the sera of those patients, only 50% of them before the onset. So, okay, from an early phase, we have a problem here because 50% of patients will be negative to the classification criteria biomarkers. So this is one of the areas where we have invested in order to find some potential candidates that could increase this percentage of seropositivity in early phase of rheumatoid arthritis. We know also that the citrulinated peptides has been associated with the severity of the damage of the joints. In fact, usually the citrulinated peptide positive patients will have a higher score compared to the ACPA negative patients. And if we take a look into the peptides, usually traditionally the peptide that was isolated and identified and used by laboratories has been the filagreen, which is canonically called CCP2. However, some years ago, we developed a synthetic peptide which has some conformational advantages because we put it some positively charged amino acids which guarantee us multiple reactive citrullinated epitopes, which is increasing the overall sensitivity, especially in early RA. So by using a synthetic peptide over the classical CCP2, we are already able to improve the identification of patients with RA, especially with early rheumatoid arthritis. But of course, this is not enough. We have been working also on other biomarkers to demonstrate and to potentially be adopted in the future in the classification criteria. The first one I would like to tackle more in detail is the circulating calprotectin. As we know, calprotectin has been now widely adopted, the fecal calprotectin, so the calprotectin for the stool, to discriminate patients with inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, versus irritable bowel syndrome. So it is now widely used also in India as a very reliable tool to exclude, so to show the negativity for the IBD. However, several papers has showed that calprotectin, not only in the stool, but also the one present in the plasma or in the serum, so the one circulating, can be found in sites of immune response because it's a regulator of the inflammatory response. And it is also well known that the calprotectin is the most upregulated protein in the synovial tissue and fluid. So in rheumatoid arthritis, we can find abundant amount of calprotectin. For this reason, here you see an example of graph in which we have neutrophils, macrophages that are recruited by the inflammatory process, by the release of Th17 or GM-CSF, Th22, and where we have the cartilage destruction and bone resorption, we have the production of massive production of the calprotectin. And in fact, since this is a process which is commonly shared by also other arthritic disorders, such as spondyloarthritis, osteoarthritis, or psoriatic arthritis, or also the juvenile form of arthritis, plus other connective tissue disease, we can find there are many papers displaying also a potential utility of circulating calprotectin in patients with other autoinflammatory conditions. For this reason, there are several papers that are already proposing circulating calprotectin to be a very powerful inflammatory marker for autoimmunity. We know very well, and also I showed you at the beginning in the guideline, that canonical inflammatory markers such as C-reactive protein or erythrocyte sedimentation rates can give 1 point in the score. But those two tests are not as specific as the circulating calprotectin, because when we see all the different scoring system for rheumatoid arthritis, we see that the calprotectin is correlating way better compared to the canonical CRP and ESR. So I think that the idea to potentially include circulating calprotectin as a general biomarker in autoinflammation will see the light in the near future. And in fact, when we take a look into association of different inflammatory biomarker, so calprotectin and ESR, CRP, IL-6 or VEGF, we see that the best agreement was found, the best association was found with the different scores in RA using calprotectin. So it is clear that calprotectin is way more reliable in detecting the rheumatoid arthritis disease. And also what is very nice is that there is a perfect correlation of the level of calprotectin with the disease activity. So if we take a look into the different RA scoring systems, we see that usually the higher is the level of calprotectin, higher is the activity, the disease activity in that specific patient. You see that the remission is very low. Then the more we go into more aggressive, the higher is the level of calprotectin. This is true for the DAS28, for the SDI, and the CDI scoring system. It is also important to see that those patients that are receiving, for example, TNF-alpha treatment, we saw before we discussed about imprecision medicine. We know that not all the patients are responding to the therapy. However, by identifying, by characterizing the level of calprotectin in patients that will be treated with, for example, adalimumab, we see that those which are then responding are the ones that will see the level of calprotectin dropping. So it can be a very sensitive and reliable biomarker for assessing the response to the therapy, to the treatment. And also, this is very important, what we see is that depending on the level of calprotectin, we can expect if the patient will be responding, so a good responder, a moderate responder, or a non-responder to the different biological drugs. In fact, you see that the patients with the higher level of calprotectin are the ones which will be responding in a good or moderate way, while the non-responders will have a lower amount of positivity to the calprotectin. So it can be very, very important. And again, here's the same with the different subunits of the calprotectin. We see that the higher the level are the ones which will respond to the therapy. So I believe this biomarker, which is, as I said, already used in certain contexts in Europe and in US, will see the global adoption in the near future because it seems to be a very useful and reliable biomarker for the activities I showed you. And then moving to other biomarkers, the other category I would like to describe briefly today are those called anti-CARP, which are carbamylated peptide. We know that certain epitopes can be targeted in a post-translational modification things, and the immune system somehow in array seems to react and to attack those peptides which are modified. We have seen the citrullinated peptide in which the PAD enzyme is mediated, the citrulination of the arginine into a citrulline amino acids, creating this citrullinated peptide. But we can also have another post-translational modification, which is called carbamylation, in which certain lysines from peptides can be reacting, generating homocitrullin amino acids. This gives a generation of carbamylated peptides. Those carbamylated peptides have been originally described in 2012 and actually in 2011 from a group in Netherlands. And in this paper, we're showing that if we analyze patients that are ACPA negative, so they don't have citrulination, we are able to identify 16% among the negative, which will be CARP IgG positive, and 30% will be CARP IgA positive in ACPA negative. So they were somehow describing an interesting cohort of patients which can display CARP positivity in a context of ACPA negativity. And the interesting part is that once they were following, for example, the ACPA negative patients which were CARP IgG positive, you see here actually that the test itself is quite specific. However, following this red segment, this red portion of CARP IgG positive, you can see that following then those patients, the bone damage was way, way higher. So the aggressivity of the disease was way higher compared to the anti-carbamylated negative cohort. There are some speculation ongoing on the reason, but it seems to be, it has been replicated by the different more recent articles published in the recent years. So it seems to be always or almost always the case. Another important aspect of the CARP, as we said, it is shown to be present in a good portion of patients. What happens now if we combine the CARP together with the two biomarkers which are recommended by the classification criteria? So by using ACPA, rheumatoid factor, and anti-CARP, We can, of course, identify monospecific patients, but we can also identify triple positive patients. And those triple positive patients will have a very high odds ratio, which I can show you also here, especially in the pre-rheumatoid arthritis patients. We see that the odds ratio, it will dramatically increase if we include also in a profile manner the use of anti-CAR-P. And in fact, I show you 3 papers in which the 3 antibodies were combined. We are basically able to identify between 10 to 20% of patients that are 100% specific. So usually triple positivity mean certain disease. So for sure, we can conclude that the triple antibody are then rheumatoid arthritis patients. We said that one of the major problems we have today with rheumatoid factor and with the APA is that they are not so frequent in early rheumatoid arthritis, because we said that rheumatoid factor and APA can be found in 50% of patients just before the onset. If we go more in details, the APA are usually found in 20% of patients 4 years before the clinical onset. So it's very, very small portion. If we see the rheumatoid factor, it is slightly better because we are around 25–30% 3 years before the onset. But the interesting aspect is that somehow the carbamylated process, the molecular mechanism itself seems to occur much earlier, up to 6 years, and in at least 50% of patients. So you can see that this biomarker can be very, very powerful also in identifying patients before the onset, so at early stage of disease. So we believe that this biomarker, combined with the classical ones, will bring powerful information input about the patients. Moving then to the final part of my talk. This is the last family I would like to discuss. So we said that the PAD enzyme is the peptidyl-arginine deaminase, is mediating the process of citrullination. However, since now 12 years, is known that the immune system itself can also attack those specific PAD enzymes, generating autoantibodies. There are 3 major PAD enzymes which are mediating the deamination of the arginine, and they are PAD4, PAD3, and PAD2. Regarding PAD4, as I said, there are now several articles showing the benefit of determining PAD4 prevalence in patients with rheumatoid arthritis, because what you can see here, we have, it is a specific biomarker which can be found in at least 1/3 of the cohort of rheumatoid arthritis. Around 20% of positive patients will be CCP negative, so very, very helpful in closing the seronegative gap, but also at least 16.7% will already display positivity to PAD4 antibody in an early stage of rheumatoid arthritis. So this biomarker will add a very powerful, diagnostic tool to close more the seronegative gap, which we know is present in rheumatoid arthritis. Here I want to show you also some other features of the PAD4, especially related to the erosive disease. As you can see, there are now several papers published, and the vast majority of them are not only underline the value in diagnosing patients with rheumatoid arthritis, but also somehow an indication of more erosive disease compared to the PAD4 negative. And then moving into the other 2 biomarkers, the PAD3 and the PAD2, the situation is slightly different, because if we take a look into the PAD3, overall the sensitivity is not very outstanding, I would say, because less than 15% of patients will display PAD3 positivity, you see here. But the interesting aspect is that As I said at the beginning of the presentation, we know that lung fibrosis, interstitial lung disease, and pulmonary hypertension, which is linked to this progression, can be observed in a 10 to 12 to 15% of patients with rheumatoid arthritis. Those patients are the one with the poorest prognosis. So life expectancy in patients with fibrosis in the lungs with RA is 2.5 years. And we know very well that when the fibrosis started, so usually those patients are identified in a late stage and they are refractory to the canonical treatment for rheumatoid arthritis, don't respond to methotrexate, they don't respond to DMARDs in general, to biologics. But if we see this anti-PAD3 positivity, actually the majority of them are the one with interstitial lung disease. So potentially identifying this cohort, this cluster of patients will tell us, will underline the fact that those are the patients with the highest risk of developing interstitial lung disease, which is of course extremely important. We are doing more studies to validate this data, and the data are somehow in agreement with what I'm showing you here. And then the last one, which I would like to underline, is the third autoantibody related to the PAD family, which is the PAD2, the peptidylarginine deaminase 2. If we characterize patients with anti-PAD2, you see that we have around 16.9, so 17% of patients will be anti-PAD2 positive. It is interesting to notice that we have only a minor overlap with the positivity to PAD3 and PAD4, which is not a surprise, because if we characterize patients which are anti-PAD2 positive, those patients will display a more moderate evolution of the disease. First of all, as you can see here in green, the number of swollen joints will be way lower compared to the anti-PAD2 negative. So anti-PAD2 positive patient will have less swollen joint. The frequency of interstitial lung disease will be way lower compared to the PAD2 negative, which makes sense, because if we said that the PAD3 is more linked to the ILD, to interstitial lung disease, and we don't see much overlap between the two, it's not a surprise that anti-PAD2 positivity is not associated to the development of interstitial lung disease. And also the frequency of radiographic progression is not related. So the PAD2 positivity don't have a very rapidly progressing disorder. So to conclude on this anti-PAD antibodies family, we can see that we have somehow, depending on the PAD positivity, we can have more aggressive or moderate disease. So with the anti-PAD2, we will have a lower risk of ILD, we will have less swollen joint, we will have a slowing progressive disorder. On the other side, the more PAD3, PAD4 phenotype will be more associated with erosion, more associated with interstitial lung disease. And so this is, I think, a very good potential, putting together the PAD family, the anti-CARP, together with the circulating calprotectin, to develop a panel of tests that will help us in the near future to characterize the patients with rheumatoid arthritis, and so to select the right drug to treat those patients. Thank you very much.
Yeah, okay. Thanks, Daniele. Thanks for such a great presentation involving, like, from 1967 to maybe we can say 2025 or maybe 2030. We have covered the whole journey. So
Yes.
before we start the QA session, I'll just like to thank Dr. Vanna Lal, who is our Executive Director of Dr. Lal Path Lab, for joining us. And without the support or encouragement from Dr. Vanna Lal, this webinar or this autoimmunity seminars would not have been possible. This is the second one we're doing it. So thanks a lot, ma'am. And before we start taking questions, like, there are a few questions from me also. And my first question is to Dr. Bimlesh. Sir, I like to know when do you recommend testing for PSPT or domain 1 in patient of APS?
Very difficult. I would love to do it, but unavailability, is the biggest challenge.
So where do we, like, when will you like to get a patient tested for both these antibodies? I'd just like to know that.
Oh,
Like
when you
how
would like to do
common,
it.
how
So,
common is this patient we should test them?
if you see these tests, they can be used in multiple non-criteria conditions where they are found to be positive. There is some association. And I don't think beyond that. See, the utility of this antibody over the existing is something debatable. The existing are the gold standards because they help you in majority of your patients. In a minute subsets of patients, you may require this test. Even after detailed review of this test, I was not convinced that I would be doing in majority, because if you ask Muntar Kamastai, he would be doing in majority of the patients where you don't get the test positive from the usual three outlined or detailed test available. But yes, recurrent pregnancy loss, and still you feel, and the word is you feel, there's no other way to say, but you think that it is antiphospholipid, you have worked extensively, I would be then doing this test. So that's a very important test. Non-criteria, does it impact our life? No, so I won't be doing. Then comes the thrombotic APS. You hardly get a thrombotic APS with a negative. The seronegative is not a feature of thrombotic APS. CNS manifestation, yes. In majority of the CNS manifestation, you may not get your conventional test positive in most of the time, or so in subsets of patients where you have the CNS lesion, which is not MS, but MS looking like, you may think it's a Sjogren, you may think it's an MS, or you can even think of this disease, APS. So there again, you can do it.
Thank you, sir.
But the answer is not clear. Believe me, if you ask me, is it a clear answer? I will say, no, I am not clear. That's why I said it's my whole journey to understand this disease. It's not going to end until unless see, if you have a research agenda, you may get out something. But if you ask a patient to spend, because these are costly tests, you are pushing the boundary to know more where you are going to achieve less. You're not going, the marginal utility of this test would be quite low. It's not a huge marginal utility, but they are so important. Still, we want to discuss, because if we miss some, we don't want to miss anything. But then it has to be cost effective in larger, and that's what people are trying to do. Is it cost effective? Can we just make 4 tests as a panel to screen out almost all of your thrombophilia profile? So that's again a question.
Okay, thank you, sir. And so there are few questions in the QA box. I think the first question is from Dr. Reena, and I think it's for Daniele.
Yes.
So she's asking that what's the preferred and reliable method for last 3 parameters you have described for RA? Maybe she's asking about anti-CARP, PET family. What's the reliable and the preferred methodology for that?
That's a good question. So basically, as I stated during my presentation, especially when we talk about the CARP and PAD2, PAD3, PAD4, we are working on a method which is a multi-parametric method. So working in a profiling, where basically simultaneously you will be able to determine in a quantitative way the positivity of all those analytes, so RF, CCP3, CARP, PAD2, PAD3, PAD4 together at the same time. So this is a technology that will be launching next year, and it will have all those parameters together. For the circulating calprotectin, which has been debated longly also because of the method, of the methodology. So if to use the serum, the plasma, and at the end it seems that the citrate plasma is the best method, also to avoid that some, if you're freezing the sample, some of the calprotectin from neutrophils might come up, elevating the overall level. So I believe in any case that the calprotectin itself will be for mostly not for diagnosing, but more for the monitoring progression of the disease or the therapy, while putting together the anti-CARP with the different PAD and analytes all together will give us those clusters of positivity that will indicate the evolution of the disease in that specific patient. So the final stage then for us would be to correlate those different clusters of positivity with the treatment to see what will be the tailored therapy for the specific positivity that you can encounter in different patients. So to summarize this answer, as I said, we see as a logic, because to do a single analyte alone, it doesn't make any sense. We need to think in a profile matter. So to put all together those autoantibody to characterize the patients and to discriminate between the aggressive, non-aggressive form, more bone erosion, potential progression with fibrosis, and so on. And let's say to see also which are the patients that will respond to methotrexate, which will not respond, and same story with the biologics. As I showed you, the Humira, which is now, widely used, the highest number of patients are not responding. What will happen with the JAK2 or JAK1 inhibitor, which are now entering in the market? So those are questions also to select then the right drug to be given to the right patient based on the profile of that patient.
So what will be the preferred methodology? Will it be ELISA, CLIA, or something?
No, it is we call it particle-based multi-analyte technology. So it will work with paramagnetic beads and with advanced resolution microscope. Using fluorescence, we will be able to identify. So the reaction will occur simultaneously. So we will have all the different self-antigens in beads. And based on the positivity, so on the binding that will occur, the machine will give you all the individual results. So if the specific, let's assume we have together the PAD2, PAD3, PAD4, the CAR-P, RF, and CCP3, it will tell you exactly which one is positive and how much also is positive. Because what we are also seeing is that depending on the value of for example, of the PAD3, we can have a stronger association with interstitial lung disease. So it will be both qualitative and quantitative. And so by doing that, in one reaction, which I think will take 30 minutes, we will have the full profile picture of that patient, which will allow us then, to take better decision and to better understand the specific individual.
So when we can expect these tests to be launched in India?
In India, I hope soon, but I think, we are finalizing we are on the final stage, in US and also in Europe. We have done already some validation of this new instrument in some beta sites, and we are very happy with the results and the reliability of the machine. I think in India, since there is also the registration process, I could expect to start, to have also this technology in India between end of next year, beginning of 2022, realistically. Also because the COVID pandemic was slowing down us a little bit, especially for the beta testing, but we are confident that in India, for sure, 2022, we can have this technology as well.
Okay, thank you. But now, again, I'll take a liberty to change the topic of Dr. Bimlesh. Now, I want to know from you, sir, what do you think role of these antibodies will be in RA, especially in Indian scenarios?
Okay, this is one question that I would always say. There are so many autoantibodies, and we know only the two classical autoantibodies in a clinical practice. And we can claim there are 20% of the population are seronegative. And if it is a rheumatoid, I actually feel there's nothing called seronegative. There must be some antibodies which are there for which we do not test. So yes, it helps you to label it. And as a clinician, I would be, we have done it and we have discussed it in our small group. So if I think it's a seronegative, whether I should use a drug, say rituximab in a refractory so-called seronegative, and you have used that drug and you find it quite works well, and you are surprised, is it seronegative? Then you say seronegative to rheumatoid factor and an anti-CCP. So that's a terminology. It's seronegative to these two autoantibodies, but there may be so many autoantibodies, and still a drug like rituximab can be used. I'm just trying to give an idea why I use the terminology seronegative, because of its nomenclature that we sometimes use And what Daniel was saying, out of 4 patients you give Humira, only one is where you are going. So it's not the preferred way. And that's why patients don't like to be, tested again. You want specificity, whether the drug is going to work. And again, the vector analysis that we were trying to see in RA, whether you have IL-6 elevated, CRP, and all sorts of parameters, are they going to help you in making clinical decision, whether you want to use an ultrasound or MRI? The clinical decisions are very straightforward and simple, where you say, I don't want, there are few joints which are swollen or tender, or the patient reported outcomes are quite substantial. It's not biased by some fibromyalgia underlying. They are quite substantial. The patients are doing well. So whether you are on a drug A, B, or C, so they are very important. So clinical sense is the most important. So if you see erosions, whether my sero status is rheumatoid negative or anti-CCP, I still feel there must be some antibodies which are there, which has not been looked upon. And that's why the serology of so many patients who were tested or seropositive or seronegative were tested later on to find out that they were seropositive for anti-CCP. And the disease characterizations are very important because they have an impact on a disease outcome. That's very important. They are just not autoantibodies which are there. They have an impact. How much is the impact on a clinical outcome with anti-carb or anti-pad is very, very important, because if you add another 20% out of, say, 20% you are seronegative, you add another 20 or 30% by doing anti-carb or anti-pad, you reach around another 80, 85, 86% from, say, so-called 80. So you go on to say seropositive. It's fine. So very, very important clinically, not, but the way you say, my name is Bimlesh Dhar Pandey. So it is, for nomenclature, is very, very important. For clinical outcome, you have to take decisions. What Daniel was saying, whether we'll be looking forward to find out more autoantibodies or looking at pathways which are important, is a very difficult question, whether you would like to hit this target or that target. And the disease evolves over a period. You may have a seronegativity going to positivity and then later on negativity.
Yeah.
How do you deal then? Intriguing. It's very important.
But if I can comment, when I mentioned seronegative is referred to the classical serology, of course, because it's seronegative because we are not using or we are not characterizing the right antibody. So very good point.
So maybe in near future, as Daniel has told me, maybe the end of next year, we will like to have that seronegative basket to be very smaller. The introduction of these two antibodies, or maybe some new antibodies, and like as Bimlesh sir has said, he wants to give them a proper name with a full surname and everything, so that orchestra will also be completed, sir.
Yeah.
So with this, I don't see any more questions. So I think we already beyond, we shoot out the time. So I'd like to thank Bimlesh sir for taking the time from his such a busy schedule and giving us knowledge about that orchestra of APS and all the guidelines, EULA recommendations, and so many things. And also, Dr. Daniele, he's sitting in another continent, in another country, and giving us thought about the journey from 1967 to maybe 2025, 30. We'll see all those new antibodies coming out, and our panelists, especially Dr. Vannalal, she took a time from her busy schedule, and like without her encouragement and support, I don't think we would have been able to do all this symposium from first, which was physical, now digital. And Dr. Meena Nakla, she has always been the guiding force, especially to me, as she is my reporting officer. So she always encourages us to take part in all these academic activities, and also to the WFN team, especially Dr. Vikas Worts, Bharat, and our beloved Dr. Ajay Gandhi also, because these people have come in forefront to, and maybe given us something. Sometimes we need a friendly touch from somebody to what we think to the big screens. So that's why Mr. Bharat Sharma and Dr. Vikas, they have all given us a lot of support. So with this, I'd like to thank all of you. And it was a great webinar, and hope we'll have the same type of treat tomorrow also. And tomorrow the timing is at 3:30. It's not 5:30 like today. And we all have to register, like we have separate registration from the tomorrow's webinar also. So thanks.
So Anil,
everyone.
I would
Thanks a
like to
lot.
thank the speakers also. Wonderful talks we've
Yes.
had today. And we look forward to tomorrow's session also. Thank you very much, everyone.
Thank you.
Thank you.
Thank you.
Yeah.
So thanks to the participants also. So taking out time and listening, having a patient listening when we're overshooting the time also is very important. Thanks, and hope to see you tomorrow also.
See you tomorrow.
So that we can have a great
Thank you.
presentation tomorrow also. Thanks a lot.
Bye.
Thank you.
Thank
Bye.
you.
Thank
Keep
you,
safe.
everyone. Thank you.
Thank you.
Thank you, Dr. Vimlesh. Thank you, Danielle. Thank you, Lina ma'am.
Thank you.